So I'll be speaking about acetabular defect management in complex primary and revision THRs and the different options available. So the rapid increase in the number of primary THRs, we're going to get more and more revisions as we go along, because a lot of young patients are coming forwards for surgeries and they are going to end up in revision in due course of time. So what are the indications for revision? Major indications are aseptic loosening, hip instability, periprosthetic osteolysis and infections as well. So what are the challenges that we face when we come with a complex primary or a revision THR? So what are the different causes? Basically dysplasia, osteolysis by wear and loosening of the by infection, excessive bone dissection at the time of previous surgery. These are all the causes for bone loss in acetabulum, and bone loss while explanting the implant. So in a primary scenario, where do you get acetabular bone defects? One is in dysplastic hips like Crow 2 and 3, where you see that your cup will not be sitting fully on the bone. And of course, protrusive cases, you'll have a lot of bone loss medially. In a revision scenario, as explained earlier, the different reasons, you almost always will have some amount of bone loss in a revision scenario. So what are the goals when you reconstruct your acetabulum? Restore the hip mechanics, re-establish the osseous coverage of the new acetabular component. That's very, very important. And then of course you need to get a rigid fixation either with the component itself or with the help of a graft. So pre-op planning, you should get x-rays, CT scans, normal slices and 3D reconstruction as well. MRIs can help if you have if you have a lot of metallosis. 3D printed models do help. We do a lot of 3D printed models as well. Virtual range VR planning can also be done. This is something which I saw the other day, HoloLens. You can actually check, this is a defect over here on the acetabulum. You can actually look at the implant and see how it fits in as well. And of course robotics as well does come into picture as well as you go forwards. So classification is very important before you start to reconstruct an acetabular defect. There are different types. AOS and Paprosky are the most commonly used ones. AOS is basically you're dividing into segmental and cavitary. Segmental means you have a loss of the supporting rim, and cavitary is when you have volumetric loss. So if you see here, these are the different types of segmental, and this is what a cavitary looks like. Paprosky's classification is the most commonly used one, and it's easy to actually plan your surgery when you have a Paprosky classification. It depends on if you're completely supportive, type 1, partially supported by the columns, type 2, and non-supportive is type 3. So you're basically looking at the dome, the medial wall and the posterior wall. So you have to see different things on the X-ray, Kohler's line, the superior migration of the center of rotation, the teardrop and the ischium. So these are the different types. I'm not going to go too much into depth here. I'm talking mostly about the different options that we have. So just an example, center of the head, then you have the Kohler's line, then you have the teardrop, and then you have ischial lysis as well. This particular case would be a type 3A. Okay, so let's go on to the different management options. So you have two types of management options for acetabular bone loss. One is non-biological, where you're not going to have any osseointegration in due course, and then you have biological, where you will get osseointegration in due course of time. So non-biological, you have impaction grafting in cemented acetabulum, and you also have ring and cage reconstructions. But the biological ones, you have non-cemented hemispherical acetabular reconstructions, either normal or jumbo cups. Then you have structural allograft reconstruction. Then you have the T-Mars cups with the porous metal augments. Oblong cups can also help, and cup cage reconstruction, which is already shown very nicely by Dr. Anil. And of course the custom triflan reconstructions can also help. So let's go one by one. You have the impaction grafting in cemented cup, which is very popular in UK especially. You have morcellized bone grafts, 0.5 to 1 centimeter small crotons. You wash them with H2O2 and saline and poured into the defect over a mesh. You can also reverse ream it, and then you cement your cup into place. After you put this, you cement your cup. So this does not osteointegrate over here. Then you have the ring and cage reconstructions. You can put on top of a morcellized bone graft if you want. There are two types of ring. Either you use a roof reinforcement ring or an anti-protrusive cage. Unfortunately with these, so this is how you do it. It fixes the ilium, the ischium and the pubis, but it does not osseointegrate. So the disadvantage is that you can have fracture or loosening of this in due course of time. So then you have the uncemented. Now let's go to the biological options. You have uncemented hemispherical cups. The normal one if you have more than 80% of bone contact. Highly porous coated if you even 30% of contact is enough, like a Gription cup. A jumbo cup if you want to fill up the whole gap, you can use a jumbo cup. And then you can also use wafer grafts or morcellized grafts if you have a lot of protrusio with an uncemented cup. Then you have a structural allograft reconstruction option, where you make the allograft into a figure of 7, inverted 7. You screw it in and then you ream it out, and that fills up your superior bone loss. Then you have the modular porous metal augments. This has increased porosity and high coefficient of friction, and it helps to increase bone ingrowth implant stability, and host bone preservation is also there more with this. They say with younger patients who you want this to last for a longer time, this probably trumps a structural allograft. Of course, as I said, you have to, augments have to be fixed with screws, and then you cement your final cup onto that. You have to unitize this construct. That's very, very important. Then you have something known as oblong cup reconstruction. It's quite rare. You have the bilobed and oblong cups. And the cup cage construct, which is very beautifully shown by Dr. Anil, where you put in a highly porous coated trabecular metal cup in, which kind of bridges the defect. And on top of that, you put your cage, and you put screws in your cage, and then you cement your final cup in the required anteversion and inclination. Now we have custom triflange reconstructions where you need to get, if you have massive acetabular bone loss, you have to get 3D printing of this done. So this is just an example of an African patient who came to us like this, completely failed triflanged cage. And so we took 2-3 weeks to plan this out. We got 3D printing of his done. This is a beautiful, this patient specific triflange cup with a highly porous undersurface, and it even tells us where to put your screws, how long your screws have to be, etc. And you get a model printed as well, so you can use this intraoperatively just to recheck whether you're right or not. This is the printed cup that they gave us, and you cement in your final cup at the end. So if you see, this is what we got at the end, and after 6 months he sent us a video walking. He's doing really well. So these triflange cups do really well if you have done a proper planning. Now robotics has come. We now know where the bone defect and the best bone lies. You can aim for the best bone stock and try to avoid bone loss area. So this is a dysplastic hip. You can plan it beforehand. You can get a virtual reduction model, and then you can usually aim for the right bone stock. Even in this kind of case where I had done in Delhi itself, you have a case where you have a completely posterior segmental loss over here. You can see in the planning itself that there's a big loss in the posterior end. So we just readjusted the cup position so that we can avoid that part. And this is the virtual reduction model, and you get a good cup without having to even use any graft over here. So final slide, how do you choose which option? It's a nice algorithm from Praporsky's paper. Is the hip center more than 2 centimeters above the native hip? If not, check if you have press fit stability with the trial component. If you do have it, if you're medial to Kohler's line, you're not, then you just go for a regular hemispherical cup. That means you're in a type B. If you're not medial to Kohler's cup, you have a type 2A, you can go for a regular cup. If you're medial to Kohler's line, you just put some medial cancellous allograft, and then you put in a regular cup. So type 2s, you can easily get away with a regular cup. Let's say if you have a migration of more than 2 centimeters and shape of acetabular remodeling is spherical, you can go for a large hemispherical like a jumbo cup. If it's oblong, you can either go for a figure of 7 allograft, a trabecular metal shell graft, or you can go for a high hip center. Let's say if you don't have potential for biological fixation and you have a pelvic if you don't have a pelvic discontinuity, you can go for non-biological fixation with a cage or biological fixation with TMR with augments, or you can go for a custom triflange, which I just showed you. And if you do have pelvic discontinuity, as already shown by sir, you have to check whether a healing potential is there or not. If you do have it, you try for the compression method. If you do not have it, you have to go for a distraction method, and you can take care of your acetabular defects. Thank you.